Yeah, good evening, everyone. This is Dr. Poorvi, consultant pediatrician and neonatologist, and I'm assistant professor. And sorry for the voice, I'm a little sick, and I'll hope I'll be clear throughout the session. To coming to the today's session topic, it is comprehensive study of pediatric anatomy, which is part of the basic pediatric science module 2. Before we go ahead and discuss about the pediatric anatomy, let's discuss why we have to know the pediatric anatomy and why not just understand all the diseases. So, when it comes to the pediatric age group, let it be a neonate or an infant or a toddler, their anatomy is definitely the same, but the physiology and the way the changes happen throughout this period is totally different from that of an adult. We can expect an adult to respond to a disease or anything very similarly among the different people we come across, but for the children, it is totally different. So, how are they different? Let's discuss it. Now, why it is necessary? So, whenever child comes to your routine follow up for vaccination, it is not just you check the vitals, you have to even check the height, weight, you have to look, you have to expose the major body parts with minimal clothing on the child. And because as a role of pediatrician, as a role of neonatologist, it is our duty to not just check what the patient is coming with the complaints. You have to even go beyond it and check for all these things, whether there is any bending of the legs, if the child is reaching his height as appropriate for the age or not. So, what are the common pediatric respiratory disorders we come across? It is croup, bronchiolitis, asthma, pneumonia. The major thing which will you come across in the first year of life is the bronchiolitis. This year has experienced or witnessed the major amount of RSV, respiratory syncytial virus bronchiolitis. It appears very deadly, though it is a minor thing, but it appears very deadly. The child are in very much distress. It just needs humidified oxygen and nebulization. I'm really sorry for the interruptions in between. Then, even the minor airway swellings can severely restrict the airflow. Like I just said, if we would have swallowed a small battery or anything, we wouldn't show respiratory symptoms, we would show the gastric symptoms. But in children, because even small minor airways are so small, it can restrict the airflow. So, the pediatric immune and hematological systems, one second, sorry. The pediatric immune and hematological systems form the foundation of child's defense and survival mechanism. So both systems are intricately linked. They are in the state of active maturation. So, as I said, the newborns depend heavily on the maternal antibodies. And with gradual exposure to the antigen and vaccination, they stimulate their own immune competence. The child develops its own immunity system. Now, as I said, the maternal antibodies, that is IgG, which actively immunity helps postnatally. And then initially they have the fetal hemoglobin is high in the first 6 months, which gradually transitions to the adult hemoglobin. So during this transition, that is the time period. The 6 months is the time period where you can diagnose many things like beta thalassemia, leukemia, anemia of infancy, and all this are very prevalent after 6 months of age. Why? Because after 6 months there is a sudden drop in the iron. As such, the milk contains less iron, and the reserves in the children are low. So that the complementary feeding time period, if we don't provide adequate nutrition during that, and if we continue only on the breast milk, then children are likely to face this anemia of infancy and even the preterm babies. Why? Because they tend to lose a lot of water and lot of hydration from the skin and even from the GI losses. So common condition we come across is the eczema, diaper rash, birthmarks, and hemangioma. You should know when we have to evaluate and when we have to leave it. This is a time period where there's maximum motor coordination, skeletal maturation, with their language development is there. That is why we put our children at the age of 3 years into the school. Middle childhood, that is school age, there's a steady growth, refinements of the skill, cognitive expansion, and even right now, I would say in this era, this 21st generation, the adolescence is hitting little faster. Many children are facing precocious puberty. So by 10 years of age, only you're seeing the menarche and everything in this era, which is not good, but that's the truth. As I already mentioned, prominent thymus in chest can be mimicking cardiomegaly. Now, developmental anomaly, neonate, predominantly cartilaginous bone, infant, you have see rapid growth. Then there'll be steady skeletal oscillation in the 1 to 10 years of age, and adolescent will be growth plate closure will be there. I wouldn't dwell much on this, but one thing we remember, it is corresponding to the CVS. There'll be higher heart rate in newborns and in the infant group, which stabilizes later on. And respiratory also, the respiratory rate is higher in a newborn till 3 months of age. Up to 60 is considered normal in a newborn period. So because they have a smaller airway, and that's why the respiratory rate will be more. As the age grows, the widening of the respiratory system increases, all the organs improve. Then we have the normal 16 to 20 respiratory rate by the reach the adolescent age group. So this is it. I'm open for questions. I hope I have covered major things and I've not missed out on anything.